Hello, welcome to our Triad presentation. We are going to be covering the substance heroin today, and my name is Lindsay, and my other group members are Jota and Ashley. When talking about heroin, we're going to focus on the three different types. There is brown powder, white powder, and black tar. Brown powder can be found anywhere in the world. White powder is primarily found in Colombia and Afghanistan, and black tar is found in Mexico. So since about the 1940s, Mexico has been the biggest supplier of heroin to the U.S., with their cartels handling and controlling that in Mexico. And tar heroin is 40 to 80% pure, but there are more impurities in the black tar heroin than the other types. A chunk costs about $20 to $25 and is enough for about 2 to 5 doses. There are 15 to 20 million regular heroin users worldwide, and 3% of that use occurs in the United States. So we were just talking about Mexico being one of the biggest importers of heroin, and their imports have actually doubled over the past few years, while Colombia's imports have actually decreased. There are a handful of neurological and physiological impacts that heroin can have on an individual. One of the most common experiences for heroin addicts is this need and this want to get away from emotional pain. And so in a video that you'll see here in a couple minutes, you'll see that that is one of the first things that the addict talks about, is wanting to feel numb, not wanting to feel that anxiety, and really just wanting to feel detached. And so heroin users will feel that short term, but long-term chronic users will actually become hypersensitive to emotional distress. They will not have really any distress tolerance skills at all. A lot of individuals will use opioids in general for physical pain, right? And so an individual is using heroin to alleviate any type of pain. Again, short term, that may work for them, but long term, it's going to change their pain tolerance altogether. So if someone's using it for chronic pain and then they completely cold turkey get off heroin, their pain will feel a lot more intense than originally. When looking at the addiction portion of heroin, heroin is a fat soluble, so it crosses the blood-brain barrier much more rapidly than morphine does, which makes the rush and the feeling of euphoria a lot more quick and a lot more intense as well. When somebody stops using heroin, the body's ability to produce its own dopamine decreases, which essentially results in a diminished ability to feel elated or even feel normal. So as you can see, there are a lot of neurological and physiological impacts that heroin can have on the addict. There are more than we even covered in this presentation today. While heroin does impact the addict tremendously, the loved ones and surrounding family members also are impacted by the addiction. So what can they do? What resources are out there for loved ones? Al-Anon is a great resource. It is 12-step based, and it provides a community with individuals who have very similar experiences, right? And so whenever someone is around another person with a similar experience, chances are that it's going to reduce a lot of the shame that comes with addiction. It's going to normalize that experience, and it's going to really increase the support for the individuals who are watching their loved ones go through addiction, really. Narcotics Anonymous is a very valuable resource for the addict themselves, also 12-step based. Also is huge on reducing shame and it normalizes their experience as well, right? And a huge part of the 12-step process is sharing your story and giving it back, right? And so in the video, you'll see that an individual who was suffering from a heroin addiction got sober, went through the recovery process, and is now sharing her success story with other individuals to help them. And so that altruism, that altruistic mentality is very big in the 12-step community.
The first time I tried heroin, not only did I like it, I loved it. And it just gave me a sense of peace that I didn't have to worry about stuff anymore. I just wanted to be free of worrying about stuff all the time. You know, I was a correctional officer at the Maryland Pen, and that's when my disease started. It's a stressful place. And a lot of the correctional officers there used. I wasn't even thinking normal. I had to use because I got to go to work. And I realized that I was sick. My mother was an open person, so she told the family, you know, Joy is sick, so we have to support her. Now I realize the stress I put them under for them to see me that way. But when you're caught up in a disease, you can't see nothing but your pain. I didn't want anybody to look down on me. I didn't want to disgrace my family. So I just faked it. I figured long as I looked good, and I went to work every day, and I wasn't, so I thought, I wasn't hurting anybody. That's what I thought. The people I admired the most, and still do today, is my mother and my grandmother. You know, my grandmother was the wisest person I ever met. My mother was the strongest person I ever met. I was raised with my great-grandmother, my grandmother, and my mother. I got to run from person to person, getting love, and everybody telling me I'm wonderful. We lived around a lot of woods and unexplored areas. I love going in the woods and finding new things to do. I had a German Shepherd. She used to come in the woods with me. I felt safe because she wasn't going to let anything happen to me. I was lost in a disease of active addiction for 30 years. I saw me. It broke my heart. I saw me. And it was the most traumatic thing that I've ever seen in my life. And I cried out to God, please. So my cry led me to a phone call. And my life just started changing drastically.
We work really hard to take away aspects of addiction that prevent proper treatment. So we work really hard to take away shame. We often fail to realize how much social circumstance impacts how people take care of themselves or how they address their health care. So it's putting together a team of people who have insight into the fact that when we take care of patients, we have to address all aspects, and especially their social setting.
Now I'm a peer recovery coach at Hopkins Bayview. So I see people sick just like, I remember when sometimes, most of the time, the pain fills the room. I talk to them, I inspire, you know, and try to encourage and let them know where I come from, let them know it's possible. And the young people, I try to let them know that you don't have to waste 30 years. You can do it now.
Peer recovery coach can see someone in the emergency room, and then if that person gets admitted to the hospital, the same peer recovery coach goes up to see them wherever they are. And this fear and anxiety of being admitted in the hospital, and all of a sudden there's a familiar face of someone who I met in the emergency room, someone who knows about my addiction and is non-judgmental and understanding.
I say I'm free all the time from the disease of addiction because I'm free to choose. I didn't have a choice when I was using. And I'm free to make my dreams come true. See, I'm truly free today. You know, I'm free to love because now I'm learning how to do it because I didn't. know how to before. So, I mean, it's not the sky's the limit, the sky and beyond.
Joy's story is a great depiction of why somebody starts to use heroin, why they continue to use it, and all of the feelings that come with that. The shame, the embarrassment, the guilt, and oftentimes that prevents individuals from getting the help that they need. And Joy was able to recover from her heroin addiction, and she is sharing her story and her experience, strength, and hope with other individuals in order to help them recover as well. So I'm going to give it over to Hoda, who's going to talk about the spiritual implications that heroin has on an individual. He's also going to talk about different assessments and comorbidity as well.
Thank you, Lindsay. So I am Hoda, and I will be covering the spiritual issues of opiate addiction, as well as assessment tools and comorbidity relating to opiates. So the spiritual concerns of opiate use run very deep. It is believed that the use of opium began as early as 4000 BC. Through the centuries, opium has been used in religious ceremonies to induce a trance-like state, which enables greater sensitivity to the spiritual realm. The Greeks documented that their gods use opium for mystical purposes. However, the use of drugs is a substitute for a relationship with the Creator. In his book, Addiction and Grace, Gerald May states that God created us for love and freedom, and that attachment to substances interferes with our true purpose. Addiction hinders us from living out our original design and makes us prisoners to our own impulses and slaves to our own selfish idols. From a psychoanalytic perspective, one could say we displace our longing for God upon other things. So this is where we need God's love and grace to free us from false idols and be restored unto a right relationship with Him. Jesus took the toll so that we might be free from the bondage of addiction. Scripture states that Christ redeemed us from the curse of the law by becoming the curse for us. Scripture also affirms that Jesus has come to set the captives free. Now I will discuss a few assessment tools and dual diagnosis that usually accompanies opiate addiction. Most assessment tools are categorized as either risk stratification or opioid misuse tools. Some of the risk stratification tools include the opioid risk tool, which is a brief self-report screening tool for those prescribed opioids. The Diagnosis Intractability Risk Efficacy Score, which helps predict outcomes of prescribing opioids for chronic pain. And also the Prescription Drug Use Questionnaire, which is designed to identify patients who may be misusing their prescriptions. A few of the opioid misuse screening tools would include the Addiction Behaviors Checklist, which is designed to track behaviors and characteristics of addiction, the Opioid Misuse Measure, which assesses for deviant behavior with those with opioid prescriptions, and finally, the Pain Assessment and Documentation Tool, which is used to facilitate and document the ongoing evaluation of a patient's level of pain and their pain management. The consumption of opiates results in substantial comorbidity and mortality. The most common medical conditions associated with opioid use disorder are viral infections such as HIV and hepatitis C, which over 50% of IV users contract. Polydrug use is also common. Opioid users will often use such things as cannabis, stimulants, and benzodiazepines to either reduce their symptoms of withdrawal or to enhance their high. Individuals with opioid use disorder are at risk for the development of mild to moderate depression. In some cases, this includes major depressive disorder. Other dual diagnosis includes insomnia, especially during periods of withdrawal. Antisocial personality disorder is more common with opioid users. And post-traumatic stress disorder is also seen with increased frequency. So now I will turn it over to Ashley, who will discuss some treatment interventions, medication-assisted therapy, and best case practices for long-term sobriety.
Thank you, Jota. With the growth of the opioid epidemic, the treatment of heroin addiction is essential to help users reduce usage and other related clinical and social problems. Beginning with the history of treatment of heroin addiction, during the first 2 decades of the 20th century, opioid addiction was thought of as a medical condition, therefore treated by medical physicians. And Abbott and Cohen explained that the production of heroin became illegal in 1924. But at that time, any doctor who attempted to treat heroin addiction outside of one of the 2 federal heroin treatment facilities was subject to prosecution themselves. Understandably, as the laws increased, so did the prison population, with federal narcotic violations making up 1/3 of all prisons during the early 20th century. Fast forwarding to 2011, 51% of the federal inmate population is being held on drug charges, highlighting the obvious that there is a direct correlation between the availability and accessibility of treatment options for users and their potential to face eventual legal ramifications without intervention. There are several barriers for treatment that a heroin addict will have to overcome in order to achieve long-term sobriety. The most prevalent initial barrier is the undesirable side effects that are associated with quitting. Physical symptoms include severe pain or discomfort, sweats, chills, diarrhea, nausea, vomiting, and insomnia. Emotional and behavioral side effects can also include extreme agitation, anxiety, and depression. These physical and emotional side effects can become so severe, more often than not, an addict will be compelled to relapse to alleviate these harsh symptoms without pharmacological intervention. In fact, opioid addiction has the highest rate of relapse out of any drug, partially due to the severity of the withdrawal symptoms. Other treatment barriers include lack of finances or medical insurance, overcrowding and lack of beds at in-state run or federal drug treatment facilities, underlying mental health issues, and a lack of family and community support. Treatment for opioid use disorder usually involves long-term treatment, and it typically begins with some type of detoxification with the use of an opioid substitute medication protocol. There are currently multiple available medications to be administered during the detoxification stage of treatment to relieve cravings and physical symptoms. A number of studies suggest that pharmacological treatment can help an addict remain committed and involved in treatment programs. I will be talking more about maintenance-assisted therapy momentarily. After detoxification, it is highly recommended that a heroin addict continue on to a higher level of care, such as a residential treatment facility, anywhere from 30 to 90 days to build a strong foundation in their sobriety through addiction education and therapy to address underlying mental health concerns. A step down from residential treatment would be partial hospitalization, or PHP, where an individual would begin to gain a bit of freedom back by living outside of a treatment facility in either sponsored housing or apartments, but they still will be medically supervised and have the accountability, usually by drug testing, to remain sober. The next step down would be an intensive outpatient, or IOP, where an individual will return home or transition into a sober living community, possibly return to work or school, and continue to attend meetings and individual counseling 3 to 5 times a week. Maintenance-assisted therapy, or MAT for short, is one of the most common and most successful styles of treatment for those in recovery from heroin. Within the recovery community, there is a common misconception that MAT just substitutes one drug for another. In reality, MAT for some, significantly reduces their potential for relapse because it relieves withdrawal symptoms and lessens psychological cravings that create a chemical imbalance in the body. In other words, MAT programs provide a safe and controlled level of medication to overcome heroin abuse. Research indicates that MAT has no adverse effects on an individual's intelligence, mental capacity, physical function, or employability. Methadone, buprenorphine, and naloxone are three of the most common medications used to treat opioid dependence. Maintenance-assisted therapy can be utilized in the treatment of opioid dependence and is safe to use for months or even years. Methadone has been used to treat opioids since 1965, with varying degrees of success. Methadone reduces cravings and withdrawal symptoms while also reducing the rate of relapse when used correctly. Used incorrectly, the drug becomes less effective, with the potential for abuse when taken in high dosages. Alternatives to methadone, such as buprenorphine, have risen in popularity since the beginning of the 21st century, with the first successful approval from the FDA in 2002. Unlike methadone, which has to be closely monitored and usually dispensed in a structured clinical atmosphere, buprenorphine has been permitted to be prescribed by physicians, which has increased treatment access significantly. Naloxone is a non-narcotic opioid receptor antagonist that blocks the effects of opioids and opioid receptors in the brain. One of the most current popular medications used for MAT is Suboxone, a buprenorphine and naloxone combination. In addition to MAT, there are several other best case practices that studies have proven to be effective to assist with long-term sobriety from heroin. Motivational interviewing is used to increase an individual's motivation to create change. Skills training to increase resistance to use. Behavioral therapy such as CBT and DBT is often applied to help an addict replace their drug use with more rewarding and healthier activities. In addition, it is always recommended that an individual engage with others within the recovery community for support through group therapy, peer support groups such as Narcotics Anonymous, and family counseling. According to the American Psychiatric Association, an estimated 2% who use heroin die each year from their drug use, and only 20 to 30% of all heroin addicts will achieve long-term abstinence. We are in the midst of an opioid epidemic, with more and more users switching to heroin daily to achieve that escape from reality and to numb their pain. The key to recovery is learning a new lifestyle, trading in a life of risky and potentially deadly behavior for a chance to build meaningful relationships and create a new, satisfying life free from the bonds of heroin addiction. Few will achieve it, but through the help of substance abuse treatment and continual support from the recovery community, there is life after heroin. On behalf of Lindsay, Jota, and myself, thank you for watching. We hope you have enjoyed our presentation on heroin.